Hi, everyone. My name is Vincenzo Berghella. Welcome once again to AJOG MFM Live and an update on our latest issue, in this case, January issue. Happy New Year to everyone, and welcome again to my co-host, Mo. How are you?
I'm great, Vincenzo. Nice to see you. Hi, everyone. Thanks so much for joining. I'm Mo Mhatre. I'm one of the maternal fetal medicine attendings at Tufts Medical Center and the director of the MFM Fellowship at Tufts. Really excited to have everyone kick off 2026 with these fabulous sets of articles to present. For those of you who are unfamiliar with our format, we select 4 articles from this month's issue that we want to highlight. We feel that they're a rigorous study design and are very helpful in either counseling or management of patients, either in the inpatient or outpatient setting. And we really try to apply or choose articles that are going to be helpful, not just for our MFM colleagues, but also for all of the other obstetrics providers who care for patients in the community. We have the articles listed here, and we're going to be using visual abstracts. This month, I've created the visual abstracts for the papers, and we're going to have a kind of a overview highlight for the papers, but we really encourage you to look at them and read them in detail on the AJOG MFM website. And Vincenzo, why don't you start off with the first paper?
Yeah, this one is a meta-analysis of randomized controlled trials. The Pink Journal tries to kind of look at the totality of the data and kind of give the bottom line. And it's an important issue. It's, pain control at cesarean section. There are more and more C-sections, and obviously they should be as pain-free as they can. There are many, many ways to do that. And one of them is lidocaine patches. So in our group, we found 3 randomized studies, 219 pregnancies, so not large numbers, small numbers, but the lidocaine patch compared usually to placebo patch, without medication, was associated with decreased pain scores at 12 hours, 24 hours, and 36 hours, which were some of the primary outcome of the paper. And obviously the lidocaine kind of wears off with time, so pain scores later on. As well as opioid use and adverse reactions, where there was no difference with that and the placebos. So, not a lot of data, but the data that there is on lidocaine patches is significantly, positive and effective for decreased pain. So we do use it sometimes, and I think especially people that may have higher, pain, that maybe you cannot do some of the things you do routinely, like NSAIDs and Tylenol. This is certainly something that can keep them hopefully off opioids and into safer pain control interventions.
Excellent. The second paper is evaluating the utility of fetal growth velocity as a predictor for SGA at birth and other adverse perinatal outcomes. And so this study was a systematic review and meta-analysis, really trying to look at the data out there of seeing can the change in the fetal growth velocity over the course of the pregnancy better predict these 2 particular issues. There's about 185,000 pregnancies in total out of 21 studies that looked at SGA, and 164,000 that looked at specifically for the association of fetal growth velocity with adverse outcomes, including stillbirth. What they found was that the slowing down of the fetal growth velocity was really not a great predictor for SGA. It overall had low sensitivity. And there was some moderate association with an increased risk for adverse outcomes, including IUFD. One of the challenges that the authors found when performing this study was that there was a lot of heterogeneity. Even the fetal growth curve was variable between studies. There's some customization of percentiles that people use, even if they use Hadlock. So it was a little bit challenging to really compare apples to apples. And in addition, there's this kind of intervention paradox, right? If you know someone has FGR, or maybe they're slowing down, or maybe there's abnormal Dopplers, you might act on it before the stillbirth actually happens. And so that might attenuate some of the association that you would have seen otherwise if you kind of let nature take its course. So the authors concluded that fetal growth velocity standalone is not, right now, there's not great data to support it as a standalone predictor of SGA or adverse outcomes, but certainly kind of using it as a supplemental tool or an additional tool to stratify risk for a patient, help you combine that with risk factors and the Doppler studies to identify patients who might be at higher risk for adverse outcomes and use that in your approach to managing them.
Next one I'll do is an important clinical issue, looking at oxytocin dosing during a trial labor after C-section, during a TOLAC. We do know, obviously, there is always a risk of uterine rupture during a trial labor after C-section. This is a meta-analysis which included 21 studies and over 51,000 patients, so it's pretty big. And this has been shown before. Basically, the uterine rupture risk does increase if you use oxytocin. Obviously, that maybe not oxytocin itself, but the fact that the labor is going slower, and so there are other risk factors that are confounders that may be associated with the uterine rupture risk. But the main question was also, how much oxytocin to give. And interestingly enough, the data didn't show a relation to the initial dose. You start with 1 or 2 or whatever. But if the interval in between doses is less than, more frequent than 30 minutes, like 15, 20 minutes, there was an increased risk of uterine rupture. And also if the maximum dose of oxytocin went above 20, that there was a high risk of rupture. So, we need to use oxytocin sometimes during TOLACs.
Yeah.
I think, we need to keep an eye on the uterine rupture rate, which goes up a little bit. And probably I would suggest, increasing it every 30 minutes, not more frequently than that. And, once you get to 20 milliunits, then, you kind of stop there. You may end up, have repeat C-section, but at least mom and baby are safe. So interesting data from over 51,000 patients.
Really big study.
And Dr. Nicoli deserves a lot of credit here, the primary author, for doing a lot of work on this meta-analysis. Excellent.
And our final paper to present this month, this is evaluating physical activity during pregnancy and its relationship with depression, anxiety, and stress. This was an RCT performed across multiple centers in Spain. And what they evaluated was, we know outside of pregnancy, exercise is good for you. It makes you feel better. That's a common knowledge. And we also promote exercise in our pregnant patients. And this group wanted to see, kind of how would a structured, supervised exercise program really correspond to decreasing rates of prenatal and postnatal depression and anxiety and stress, which we know can certainly happen to our patients. So these were singleton pregnancies, and they were randomized early in pregnancy from 12 to 16 weeks, who had no contraindications to exercise and no history of a mental health disorder. And they randomized groups to either having 3 times a week an hour-long exercise program. This was initially started right before COVID. So it was initially all in person, and then they switched into Zoom. And then once the pandemic died down, they did a bit of a hybrid scenario. But they continued this exercise regimen until delivery. The control group was having the routine prenatal care. They were educated about the importance of exercise, and they were given some educational handouts to encourage them to be healthy. And then the team evaluated the patients throughout the pregnancy and at the end of the pregnancy to look with standardized scores for depression and anxiety and stress. And they did find that there was a decrease in the scores for anxiety and depression for the patients who were having regular exercise regimen, and especially the patients who were particularly adherent, meaning at least 90% adherence to the program, the scores dropped significantly. And so this is a really interesting study. I was impressed how much they were able to accomplish during the COVID pandemic, especially when things were really limited. And so there certainly seems to be a trend towards physical activity and supervised activity, improving or reducing the rates of depression and anxiety, especially with high adherence. And I think this group is looking to do more of an in-person evaluation with a larger group and see if the outcomes are the same. So I look forward to seeing what they accomplish.
Great. Thank you, Mo. Another very informative sessions. Thanks to all of the people who follow you, follow us. There's so many of you, and we are humbled and happy that you follow us in many, many ways, including the podcasts. And we look forward to February, and Happy New Year to everyone.
Thanks, everyone. We'll see you next month. Have a great day.
Bye-bye.